Hello, everyone, and thank you so much for joining us today. Today's webinar is the fifth in our series discussing the opportunities for tribes in the American Rescue Plan. Today, we will be having a conversation with Stacy Bolin, Del Lavadeur, and Lynn Malerba about how tribes can maximize their American Rescue Plan opportunities. My name is Karen Diver, and I serve on the Board of Governors for Honoring Nations. I'm a graduate of the Harvard Kennedy School, which is the virtual site of today's program. I was formerly the chairwoman of the Fond du Lac-Banda Lake Superior Chippewa and served in the Obama White House as Special Assistant to the President for Native American Affairs. I currently work at the University of Minnesota as a Senior Advisor for Native American Affairs to the President. I want to start today with a few announcements on behalf of the Ash Center at Harvard, which is our host for today's program. In particular, the Ash Center would like to acknowledge the land on which Harvard sits as the traditional territory of the Massachusetts people and a place which has long served as a site of meeting and exchange among nations. This event is being recorded and the video will be made publicly available on the Ash Center YouTube channel and through the website of the Harvard Project on American Indian Economic Development. You are welcome to submit questions at any time throughout today's program. Please use the question and answer button, not the chat button. And we will answer those that we can live and or log them for future follow-up. Now I'd like to introduce our distinguished speakers that are joining us today. Firstly, welcome Stacy Bolin, CEO at the National Indian Health Board. Prior to joining NIHB, she was Director of Federal Relations for the American Indian Higher Education Consortium, Deputy Director of the American Osteopathic Association's Washington, D.C. office, and served on the staff of former U.S. Congressman Bob Traxler. Marilyn Lynn Malerba is the lifetime chief of the Mohegan Tribe. She is chairwoman of the Tribal Self-Governance Advisory Committee of the Federal Indian Health Service, IHS, and a member of the Justice Department's Tribal Nations Leadership Council, a member of the Tribal Advisory Committee for the National Institute of Health, a member of the Treasury Tribal Advisory Committee. She serves as the United South and Eastern Tribes Board of Directors Secretary. Also joining us today will be Del Lavadeur, attorney and former Assistant Secretary of Indian Affairs at the Department of Interior. We do have two quick updates before we get started with today's panel. The Treasury Department updated their FAQs on FAQs on July 14th, and they are specifically about infrastructure. So if you have additional questions about infrastructure and ARPA funds, please see the updated FAQs on the Treasury website. You should also note that the second allocation of ARPA that is based on employment verification, the deadline to submit your employment verification information has been extended until Friday, July 23rd. And those are the latest updates we have on the distribution of ARPA funds to date. So we're going to get started by starting with Del Lavadeur. Del, you've spoken so passionately about addressing behavioral health needs in Indian country, and we've had extended discussions amongst our planning group about the additional trauma that has been brought into Indian country during the pandemic. The loss of our elders, the stressors around economic security, exacerbating mental health and behavioral health issues. We've seen an increase in opioid deaths, and this is all on top of, dealing with generational and historical trauma as well as current trauma in Indian country. It seems that there's been a mental health and behavioral health crisis that has gone on concurrent with the pandemic. I think you want to share with us some information today to help us set the conversation around behavioral and mental health. So I'm going to turn it over to Del.
Thank you, Karen, for that introduction, and just welcome the audience, and glad to be here with my fellow panelists here and start the conversation off with perhaps some definitions of trauma, types of trauma, different healing modalities. And as Karen said, it's been a very difficult 16 months ever since the pandemic arrived in the US and has really revealed, I think, a lack of investment and underinvestment in tribes' public health. And so with that, I want to go ahead and just set the table with some information on the following 6 slides. So I like this definition by Gabor Mate, who's a physician and an author. A book that was really good to read was The Realm of Hungry Ghosts, some of the work that he did in Vancouver, British Columbia. And he said, trauma is a psychic wound that hardens you psychologically and then interferes with your ability to grow and develop. It pains you, and now you're acting out of pain. It induces fear, and now you're acting out of fear. Trauma is not what happens to you. It's what happens inside you as a result of what happened to you. Trauma is the scarring that makes you less flexible, more rigid, less feeling, and more defended. I thought that was a pretty accurate description to describe trauma because there's a lot of different definitions that you could look at. Trauma symptoms, for example, many people in Indian country and some of the tribes that I work with have described these things. Things like hyperarousal, constriction in the body, dissociation or denial, feeling helpless, immobile, or freezing, hypervigilance, always on the lookout, flashbacks, extreme sensitivity to light and sound, hyperactivity, startled responses, nightmares, abrupt mood swings, shame and lack of self-worth, difficulty sleeping, and the list goes on. As you know, those symptoms are indicative that people could be experiencing trauma, and I think many in the country are as a result of the pandemic, especially with the isolation and lockdowns, not being able to do things that tribal communities normally do, which is get together for meals and feeds and have giveaways and go to graduations. And it's been very disruptive and disconnecting. So a lot of those symptoms are going to show up. And in terms of the types of trauma, which I think are definitely prevalent in Indian countries, shock trauma from grief or loss of somebody close to you, developmental, what happened as you were growing up, and having, on average here in the plains, say 15 people living in the same home. There's a lot of things that happen. Transgenerational. There's the ACEs study, which talks about all of the factors that go in, and there's a quiz online, and maybe we'll have a link to that after the show for people to look at that. And for example, in the transgenerational trauma, which I certainly felt, and maybe many of you did as well, when the epidemic came on, I felt this sense of fear and like a dark cloud was coming in. And it made me reflect back on some of the stories told here at Crow about the last epidemic, which my grandparents talked about. And they said that people were getting sick and they didn't know what to do, and they didn't know where it's coming from. And at that time, the Indian Health Service was not in existence. So you had to go to the traditional remedies that they had at the time. In addition to intervention and seeing your regular physician, and then also perhaps having prescriptions to help with some of those, there are these other healing modalities in addition to those. Somatic experiencing, which I'll share. I've got a provisional certificate in somatic experiencing, and I'll share a couple slides with you. Neuroaffective relational model, NARM, eye movement desensitization reprocessing, EMDR, compassionate inquiry, emotional freedom technique, EFT, it's tapping, internal family systems, which is a growing modality that a lot of people are using, brain spotting. I've heard a number of Indigenous therapists who use brain spotting in their practices with their clients. Psychedelic assisted therapy, the MDMA. There's more and more science coming out on that about microdoses of those can be helpful for mental and behavioral health issues. And polyvagal theory, looking at the nervous system and how our nervous systems are formed and react to these variety of different types of trauma. Next slide, please. Just to give you the statistics, and I think actually these are low, the 2.5 times rate of the normal population of COVID infection, I read on the IHS website yesterday, it was actually 3.5 times. That 2.5 times death rate, I believe that's even higher as well. Suicide, major epidemics of suicide in Indian country, second leading cause of death, according to the statistics from 2019. 12 times overdose rate from meth. And then this last one is to demonstrate how much of the population actually has been impacted by the recent revelations of the boarding school issues with the mass graves that are found, and then the initiative by Secretary Holland to examine that and to find out and provide a report next April. So you can see Indigenous is on the highest end of all the different races. Next slide, please. In addition to all of that, this is a patient's journey and in New Mexico. And if you look at the inside the circle there, that's the only part I'll focus on is acceptability. Like, I need help. A person has to decide that they need the help and that it's okay to ask for help. And then even after you do that, is it available? Who is there to help you? Are there therapists? Are there those who understand what's happened in your journey? Accessibility. How do I get to the appointment? If you're in a very rural area, there aren't that many providers. So that's a challenge as well. And affordability. How do I pay for these services? Especially if they're private and they're not funded by or have somebody at their tribal clinic from Indian Health Service. Next slide. Here are some efforts that have been highlighted, and you'll have links to these. There's videos, there's reports for you to look at. But we just wanted to provide some examples of where people are trying different initiatives that have been successful in tackling some of these challenges. The Chickasaw Nation Medical Family Therapy, in that case, they combine physical and behavioral health to get holistic care. The Indigenous Yupik Wellbeing have elder-driven traditional healing. The Maram Health, whole life approach to health, and so on and so forth. And then the Alaska Native Health Consortium's behavioral health. They've got a very holistic model up there, and they've done a wonderful job of combining a lot of different modalities. You have school-based health centers. White Earth has a suicide intervention team. Over at Flathead, they have emergency information available for people for 24/7 service, which is great. And then Harvard Nations and New Mexico Indian Affairs providing a report to talk about the different tools and the challenges. Next slide. So this is one of the SC for crisis stabilization and safety aid. The World Health Organization and 17 neuroscientists have reviewed this material, and now we're going to make it available. But if you look, you can get this yourself on traumahealing.org/scope. And all it is a way of, whenever there is a crisis, to remind people they have the internal tools to rely on and get and hopefully come out of the crisis. So that's why they named it SCOPE, is for slow down, connect to the body, orient, meaning look around, don't get fixated on any particular point, because that's what trauma often triggers or activates in a person, is the fixation on whether it's the virus or the people getting sick from the virus and hospitalization, etc. And pendulate is when you're going in and out of the trauma vortex. So you need a counter vortex. What is resourcing for you? And in particular, looking at breathing in order to get through a crisis situation. And then finally, engage. So if all those other pieces are there, you can still engage socially. And that's a very good indicator of being out of the crisis. Next slide, please. The final slide, and this is tools in development. It's some places in Indian country are looking at these other modalities to go in addition to their traditional healing methods, whether that be the sweat lodge, other ceremonies. It basically gives kind of a sequence in order to stabilize. So you assess primary safety, acknowledge reality. Yes, I'm here now, and it is a crisis. Anchor to the here and now. You're not in the past, in a previous trauma situation, and you're not in the future wishing you were out of it. You're just admitting that you're in the here and now. And then you would pause, apply a stabilization tool, and then discharges in the SE world anyway, that your body has some responses that it wants to do. So you facilitate those responses in order to get that out of your system and resolve the trauma. And then finally, it's connect, rest, mend, attend, and then you have a safety cycle plan, and you repeat as needed as you go through the crisis. So I just wanted to provide these slides, and they will be provided to you after this webinar, and to set the table for the conversation with the fellow panelists.
Thank you so much, Del. A lot of our intention with today's webinar is to normalize the discussions around behavioral health, mental health. We still have a hard time talking about it in Indian country, but yet it affects so much of our wellness. You know, we talk about homelessness, but we don't talk about underlying mental health issues that are exacerbated by chemical dependency issues as one of the causes. So much of Indian country is impacted by this, every single one of our communities. My first question is actually going to go to Stacy, and given your national scope of your work, can you talk to us a little bit about what you're hearing from Indian country about the compounding of all of these stressors in our communities and how that was exacerbated by COVID-19? What are you hearing from communities in terms of what they're going through with behavioral health issues?
Thank you so much, McGwitch. Thank you for the question. Well, we're hearing that tribal communities are struggling to, they're not new struggles, but they're more intense and exacerbated because of what we have experienced with COVID-19, such as the lack of qualified behavioral health professionals that tribes can access and rely upon to get extra help in the community, to have that professional support that they need to get through the crisis. We're hearing that people are having grieving fatigue, that from the loss of loved ones and the losses in community of community members, that there was we hear described repeatedly, there was a moment of numbness that happened along the way. And then as the tide of the pandemic started to abate, people were able to take a breath and really think about the world as they know it now, and that grieving continued at that point and flooded back in. We're hearing a lot about people very concerned that the investment in public health infrastructure at the tribal level it was just completely inadequate to address a pandemic. It's inadequate to address the day-to-day public health needs of tribal communities. Of course, when the public health infrastructure was being built in the United States and investments were made in state and county public health departments, that same investment did not happen in tribal communities. And the IHS doesn't have a public health arm per se. So direct investment into the public health services in Indian country has been lacking for a long, long time, and sort of contributed to creating that perfect storm for COVID to really cause devastation. And I would say what I'm hearing and we're hearing now also is that on top of the grieving and the trauma of, for example, not being able to carry out traditional burial practices or traditional final journey practices because of the pandemic, because of social distancing requirements. We're adding to that now what we're finding with the boarding school issue. And it's layering a level of trauma and distress in tribal communities that the issue alone would be overwhelming to handle.
Thank you.
Can I add to that for a second, if you don't mind?
Please do.
Stacy, I think you are spot on with your comments there, but I also think add on to that anxiety about your own personal health, not being able to protect your family because of the public health crisis, and also a sense of grieving that you can't be with a family member when they're severely ill in the hospital and you can't even be there to comfort them. those, I think, are exactly what you meant, are thinking about and talking about, as well as isolation. So for instance, some of our communities have assisted living facilities, and so they had to be on lockdown. So the only way you could interact with your family member was if they were willing to have an iPad. And you imagine some of our oldsters aren't real thrilled with technology, right? And so they felt very isolated because their only connection to the world was either the care providers there or the telephone. So I think that that's, another real challenge for our communities.
Yes.
Lynn, you bring up some interesting points, as well as Stacy. We shut down direct medical services, and then didn't have a great plan around mental and behavioral health. We couldn't do any kind of congregate treatment, for example, and Rule 25s were hard to come by, because you couldn't have anything face-to-face, and they were pivoting and using technology. So we're talking about, this is a part of an ARPA series. And so tribal governments have so much latitude in how they use those resources. Lynn, what does a good partnership between tribal government and their public health department look like? And if you could be that voice for public health within tribal government, what would you ask for?
So in my previous world, I was the Health and Human Services Director for the Mohegan Tribe. And so part of my role was to supervise our public health arm. And so they have been very busy, engaged with, at all levels of government, whether it was local, state, or federal, as well as Indian Health. And because we have a good relationship with our state public health department, we were able to set up a mass vaccination site. We were able to set up, drive-through testing at our, on our reservation that was open to our employees as well as the communities, because we are such a small tribe and we have such a small land base, and our tribal members are scattered throughout Connecticut, and Connecticut is a small state anyway. It made sense for us to really partner and to share resources as best we could. And we were also able to distribute some PPE using the Connecticut National Guard. So we were a distribution site. So I think it's really important when something like this happens that, if you have the ability to get all hands on deck, because this affects everyone. It's not just our tribal community that's impacted. And the larger community affects the tribe affects the larger community. And Del, I go back to what you said about the flu pandemic, in 1912. And we were very isolated back then, and our tribal members who didn't live on the reservation came back to the reservation to isolate from the rest of the world. So this time it was a bit different because we are a more global community.
To follow up, Lynn, do you have any thoughts or recommendations regarding investments or capacity in behavioral health, specifically for tribal governments?
I think we need to get people comfortable with technology for a couple of reasons. One, then the isolation is less, it's less intense. But two, because people don't always have access to good behavioral health clinicians and providers, this is a way to give you access even when you are at a distance. So I think really investing in broadband does a lot of things for us. Number one, it gets us access to clinicians, but it also gives your clinicians and your tribal community the ability to lay eyes on one another and to find out how people are doing and to do check-ins with one another, and also to do some remote cultural things, because we need to keep people grounded. Our communities are communities that had their culture ripped away from them, beaten for speaking their language and assimilated, as we all know, with the boarding schools, and whether it was boarding schools or just some of the churches that we experienced, they just wanted us to assimilate into their lifestyle. So we've been kind of resurrecting and rebuilding some of those cultural ceremonies and traditions that ground us in our indigeneity. And I think that contributes to our social and cultural health, as well as our emotional health. Lastly, using technology was a way for us to check in with our tribal members. And so once the pandemic hit and we knew it was going to be a lot, it wasn't going to be the 16 weeks, poof, it wasn't going away like a miracle one day, that we were going to be experiencing this pandemic for a long time. We literally started a phone tree and started calling each and every tribal citizen to find out how they were being impacted, how we as a tribe could help. Even though we weren't sure what kind of funding would be available, we thought the only way for us to be nimble about how we would help our people would be to actually have that conversation with them. Because once we understood what the needs were, then we would work to address that. So we kind of did it backwards, and we didn't have any funding, but we said we're going to at least develop a plan. And I think that was really helpful.
And if I could jump in here, Karen, I would agree with everything that Lynn had just said. And also just want to mention under ARPA, public health is littered throughout the interim final rule. And there's a lot of flexibility around utilizing those resources to build out public health. And I do agree with her also that it starts with broadband connection so that you can have the capacity in the system and be able to have video conferencing, et cetera. It also helps with the kids if they have to learn online, or if they're only part-time, it gives them access to the teachers teaching material and self-learning. So it really has a dual function. And the other thing I would like to mention is just the culture and resiliency of tribal communities. And I think what you're seeing is that because they have experienced, so many have experienced that and they've made it through it, there's a sense of, even though things are overwhelming and it's a very difficult time, somehow they're going to make it through it. And I think that resiliency is what we need to build on for any of the public health initiatives, and really name it and then find out how we foster it and get the resources into that so that people will have access to a lot more than they normally have.
Mm-hmm. And that is
sorry, go ahead.
Oh, sorry. That is some of the storytelling that we need to be doing. And storytelling is such a powerful tool for us, because we talk a lot about intergenerational trauma, but there's also intergenerational resilience. So we have to start telling our story about survival, right? Because we're all here because our ancestors held on. Despite all of those odds, they held on. And so I think teaching our younger kids that, we come from a very strong, resilient, adaptable people, I think is a really strong message to be giving to them. And we need to weave that into all of the activities and things that we do with our kids, because it doesn't need to be, let's sit you down and talk about this. It really is, how do we kind of keep giving them that message as they go through life and they go through some of our programming and services and the things that, we like to do with them. And I think that that's a really important point. And sorry, Stacey, for interrupting.
No, it's totally fine. This is such a robust conversation. It's exciting. Yes, everything that's been said is wonderful and true and valuable. And I also just wanted to add that, Karen, you had asked the question about partnering to make public health work for tribes. And one of the partnerships that was really, really generous during this time, I think, was the way the Walmart Corporation showed up. I know that in Oklahoma, they gave tons and tons of food to tribal communities when we were going through that period of time where the grocery stores didn't have supplies and people were, they were terrified and hungry. And the Walmart Corporation showed up and did a partnership with us. It may have been broader, but that I know of, several tribes in Oklahoma. And they did a partnership with the National Indian Health Board to get the vaccine. They used their supply of vaccine to get the vaccine to places in Indian country where it wasn't available yet. So I just wanted to mention that public-private partnership is also really, really strong, important.
Yeah, and if I could just add on to that, Stacey, for example, I think universities could play a big role as well in their research and deployment of resources, also of the different modalities for healing. And perhaps I'm involved in an initiative where we're trying to do peer-to-peer so that we get the public health professionals more tools, augment what they have, and hopefully the broadband will be put in and available, and then have providers from around the country be able to service tribal communities and help them through various issues when they need help. And I think it's important to repeat, but I remember hearing this, and I heard that, you know, time does not heal all wounds. They said it's falsehood. Trauma is cumulative, so it builds on it. So you got to work on the different layers in order to address it. And it's okay to get help. And I'm willing to admit here, I've tried out half of those modalities on that first slide that I had here just to see, and different ones will work differently for people. And whatever resonates with your system and helps you, then that's what you follow. Like if one of those tools, say it's internal family systems, if that helps you as a therapeutic model, then go with it and try to utilize those resources. And I think what you're seeing are a lot of people who are very concerned about tribal communities because of the history, and that they want to help somehow. And so we need to build those bridges so that they can become available resources for the communities.
Lynn talked eloquently about building intergovernmental partnerships. We've heard that there's different federal agency resources. Don't look just to your ARPA or COVID funds for broadband deployment. You know, there's funding coming out separately for that, but you can augment it with existing resources. Telehealth really filling in some gaps around accessibility and building on our adaptability as Indigenous folks. You know, we can pivot and fill those gaps. And then just kind of being good relations, right? Taking care of our neighbors, and also taking advantage of partnerships to fill in gaps. Stacy, you were you know, talking about, you know, Walmart filling a need that was unanticipated in Indian country in terms of food security issues. Are there any other lessons you'd like to share around either behavioral health or public health in terms of Indian country's readiness to deal with something like COVID-19?
Sure. Well, I think that you've heard a lot of tribal leaders talk about this and make this observation. And how I would articulate it is that to contextualize what we've experienced, when you look at the construct of colonization back from the very beginnings of its establishment, and you look at the long-term way that policy has been written and implemented around American Indian and Alaska Native people, from the wars on our people to the boarding schools and so forth. And then you look at the complete inadequate funding for 50 and more years that has occurred through the Indian Health Service, and couple that with the fact that, as Chief Malerba often says, these are not social programs. These are not social service programs for needy people. These are trust obligations that are nothing to do with appropriations. This has everything to do with what was negotiated. And so you take that structure of colonization, you take that structure of all the policies that went along with it, the dearth of funding for our health, and you ride it up through 2020. And when COVID-19 happened, the outcome and the devastation on our people could have been planned. I mean, how else could it have turned out with that kind of social policy and lack of funding around the infrastructure, healthcare, public health needs of American Indian and Alaska Native people, the housing needs of our people, the water, the running water, the number one issue, to the number one practice to try to avoid getting COVID-19 was wash your hands often. Okay, how possible is that in many parts of Navajo Nation and with our brothers and sisters in Alaska Native communities and other communities? What about social distancing when the investment in housing has been deplorable and will take 4 or 5 generations into one household meant for one family of 4, because that is who we are. That's our resilience. That's our commitment to each other. But in this scenario, the way it played out was exactly the opposite of what was needed to have a good chance of surviving and not getting this disease. So I believe that what we have learned, I think there has been kind of an awakening. I think that the George Floyd issue and Black Lives Matter rising last summer coupled together to tell a story about what is needed in social transformation and in political policy transformation in America to make these statistics, winning the race to the bottom for the worst outcomes of COVID. It's not a place we have to be. And so I think that we can take all that we've learned from this and use this as the ground we stand on to form a transformative society in the future. That's what we're working for.
Lynn, if I could follow up real quick and then I'll get to you. So one of the things that we've been trying to highlight through the Harvard Project in this series is this is the biggest investment ever to come into Indian country through ARPA, and it can truly be transformative. And Lynn was talking about engaging her community to talk about needs and priorities and things like that. And tribes are getting stressors about what to do with that money, but yet this is some of the most flexible money to ever hit Indian country. Do you have any thoughts about key investments that tribes should be considering at this time so we don't race to the bottom? In addition to that, do you know of anything else out there that can be used in terms of funding to kind of build on ARPA, to build on CARES Act, to make these investments?
You're asking that of Stacy, correct?
Yes, Stacy.
I thought you were asking Chief Malerba, so I was just like, oh, I wonder what she's going to say. What an interesting question. Oh, I'm sorry. I missed the cue. Well, I think that first of all, I think that the grand investment in Indian country is more on par with how we should just expect that to be normal. I think that is like a normal investment in Indian country, and I think everyone is seeing it as a very significant, substantial moment. But I would strongly encourage, advocate for, and support on behalf of the tribes that this is just the beginning of setting us on a correct course of action. And actually, the organization for which Chief Malerba is the secretary has, I think, one of the best ideas in the Marshall Plan for Indian country that I've seen. So I would, if you don't mind, I would turn that over to her. That's what I was waiting to hear about.
Well, I think it is going to take a lot of advocacy, right? Because where we are today happened over centuries, all right? So, and I do think it's a bit ironic that the first healthcare program for Indians occurred in the Civil War with the War Department so that we would not give the soldiers communicable diseases. Now, there is some irony for you, okay? And with the Merriam Report, people tout the Merriam Report, as being, kind of the precursor to modern day Indian health services. But actually, during the conversation about the Indian Reauthorization Act, or what they talked about was, well, we don't want to create more Indians. We're trying to get rid of the Indian problem. This is the senator for the Senate Indian Affairs Committee chairperson talking to the Bureau of Indian Affairs. So there's this long kind of sordid history, but we didn't get here in a vacuum. This is centuries. And so we do need a Marshall Plan, and it's up to us to advocate for that. We are rebuilding our communities and we are reclaiming what was taken from us. And language is important. We didn't lose our lands. We either ceded them, probably violently, through violence, or we were hoping to protect our tribal nations by ceding them and then getting something in return. So what we have to do now is really insist and advocate on full funding and full mandatory funding for all of the public health programs, whether it's behavioral health or otherwise. And we have to think about self-governance. In the middle of a pandemic, we were still being asked to write grants. That's problematic. SAMHSA, we consulted with SAMHSA. We said all of this funding needs to go through, contracting and compacting and just get the funding out, do an interagency agreement with Indian Health Services, you can get the funding out. And they refused to. They said, you have to write a grant. And yet people tried to upload their grants to that and the system wasn't working. And they talked about, winning a grant. This is not, the mindset that we need to be thinking about. So it's up to all of us tribal leaders to really advocate for what needs to happen and what should be happening. And the Marshall Plan is just that. Let's look at infrastructure. Why do 25% of the households in Alaska have no running water? Look at the overcrowding that we have. Look at the fact that our clinics don't have negative air pressure, so you can't isolate a patient even when they are diagnosed. Look at the fact that there weren't even enough test kits. So all of those things, we need to harden for our communities, and we need to make sure that we're ready for the next time, that we have PPP and we have PPE and we have stockpiles. But it really does matter. And I think we need to work with our committees of jurisdiction. All of our organizations need to be on the same page. All of our tribal leaders need to be on the same page because we can make a difference. And I think, Congress recognized the fact that for far too long we've been underfunded, and this is exactly the result. Our people were hardest hit in this United States.
Yeah, and if I'll tag team on that by the Chief Malerba, Karen, and so it starts with ARPA, right? Flexibility, a lot of resources, your infrastructure, broadband, public health. That's the initial infusion. All the agencies that have direct services to natives, Interior, HHS, have huge bump ups. So we want to protect that in the appropriations process and have a higher threshold per year so they can protect these investments and have ongoing operations. And then now there's the infrastructure bill, which is being negotiated, and there's a huge set aside for tribal nations. And so they can get the basic infrastructure in addition. So you have a 1, 2, 3 process, and we have to keep it going. We have to keep advocating to have that happen. Even though these are pandemic related, what we really want to see is the appropriations year to year go up, have a higher base, and then ask for more to be funded in public health, which has been, as Stacy said, underfunded for a long time. So I think there are those resources that are on the horizon, and we'll have to just keep advocating that those top line numbers keep moving up.
This brings to mind, when you were talking about, innovative approaches by tribal government and tribal health professionals. A lot of our innovation is directly informed by who we are as Indigenous people, right? We talked about our community-based approach and our care for one another and our regard for our elders and keeping them safe. Lynn, from your perspective, both as a provider, tribal leader, elder, I would say, right?
Yeah, too bad.
Yeah, I mean, that's an important place to be, right? Talk a little bit more, if you would, about the role that kind of looking at wellness and medical care and behavioral health and that holistic approach, why that really matters for Indian country.
So we don't separate health as physical health. We look at social, cultural, emotional, spiritual, and physical health all together. So it's not separated. We're not even separated from the land. We don't separate ourselves from our land. We think our land is part of us. We don't separate ourselves from the other animate beings in our world. The federal government does not run that way. They're very siloed. And that's one of the things that we're trying to advocate for is, how do we get to self-governance in some of the other agencies, for instance, Health and Human Services, because that agency has so many different departments that impact those social determinants of health, including SAMHSA and NIH and CDC and child development and elder care services, all of those things. And we look at our tribal community as a continuum. We talk about the trail of life. We're all on the trail of life together, and we're all there to help each other on the ups and downs of life, right? And it doesn't matter if you're a youngster or if you're an elder, we are all connected. And so until we can kind of reframe, how we're providing services, but also how we're talking to the federal government and the agencies in terms of how they need to uphold trust and treaty obligations differently, and how they need to think about it differently, we are going to continue to have a little bit of a struggle with them. For instance, somebody who operates a child care center and a Head Start center can't share the same playground. That's crazy. That's just crazy making, and it's just making work for a community. And a lot of, tribal communities have their elder housing and their child care center together because they value that interaction so much. And for all of us, anytime we can touch our tribal people in a positive way, so whether it's, summer camp and doing cultural activities, or whether it's playing bingo with the elders and, having a lunch with them, all of that contributes to our community's wellness. And, all of those one-by-one interactions and group interactions make our community what it is. And so I think we need to just kind of reframe how we look at things. And that's why, I was fortunate to be the Health and Human Services Director, because I had that continuum of care, but also the plethora of services that make our community healthy. So I think we need to, engage our agencies in that way too.
Stacy, Lynn talked about the burden that was placed on tribes in terms of, having to apply for money that really, while it's a significant investment, isn't adequate to fulfill the treaty and trust responsibility, and is a good beginning. We've had during this series, people pose issues regarding getting good guidance from Treasury about how to use the money, and they were having technical difficulties, during webinars. They just were not always responsive to tribes, and they want to do this right and make the most of it. So they see it as moving goalposts, right? When we're already in the middle of a process. How and when, maybe not when, but how should tribes best deal with their congressional representatives, agencies, in order to advocate for themselves and to smooth out this process so we could get good counsel from the federal agencies, as well as make good decisions for our communities?
Thank you for that. I think that, this is the advocacy space that that you're talking about. This is the space where it's probably the most, it can be the most impactful place that tribal governments and tribal leaders can make change with their members of Congress, because, according to the Constitution, no money can be spent from the Treasury that doesn't originate from the Congress. So having those relationships is critical. And one of the things we saw, for example, with the Special Diabetes Program for Indians, that is a game changer in Indian country. Tribes across the nation invited their members of Congress, their senators, to come to tribal community, see how these programs work, see why they work, see that these programs are founded in tribal cultural values and traditional practices, along with the best that Western medicine has to offer. And because of this, has brought the hemoglobin A1C aggregate level for Indian country down 1 full point. That's an unheard of success. So I think that for as much as we have obstacles and we have a lot of catching up to do in terms of equity, there are such victories and so much creativity and success that the tribes can point to with very little investment, that I think that members of Congress need to see in their own backyard what this means. They need to be taught by tribes in their own backyard what that trust responsibility is and what that relationship is. And particularly with August recess coming up, this is a great opportunity. Members of Congress are typically home, and this is a good time to invite them out and say, we want to show you our community. We want to show you some of the practices we adopted because of COVID-19. We want to show you how we're saving our languages and how investment in us is a winner
also going to be the time where they're fundraising, if I could be so bold as to point that out. So rather than respond to correspondence, maybe ask for them to come in person and make that request. Your Congress people need to be responsive to you. You are their constituent as well, and they owe a duty to be your voice. So say it repetitively, say it loudly, and where they're not giving you attention, demand it. So that's all I got to say about that. Lynn, would you like to add to that?
Well, I think the other thing is, now is the time to use our diplomacy, right? The pandemic made the case for us, number one. And number two, we can never forget that, the United States should be dealing with us as nation to nation, just like they deal with other countries. They need to remember that this is a diplomatic relationship and this is a governmental relationship, and, I know, Stacey, you chatted about that earlier, not a needs-based, not a poverty model. This really is, we need to hold the United States accountable for, delivering what they promised on so long ago, and yet never have. And so this is the perfect opportunity, I think, to do that. The other thing I would suggest too is, we need to have more Native researchers who are doing the work on the ground, in our communities, because only our communities are only going to trust the people who come from our communities. And we need to start growing our own public health and healthcare providers. Some tribes have many healthcare providers, that come from their own nation, and others do not. We need to insist on that because it's a matter of trust. And I will tell you again, our elders, didn't matter what role I was in, they'd stop by my office and get their blood pressure checked because they knew I would tell them the truth and they trusted me, right? And that's a very small example, but when you have somebody from your community that's advising you and engaging you in your health plan, they're going to trust you more. And I think that that's really important too.
You know what, Lynn, earlier you brought up this, your community's response to COVID, even before you knew what the resources were. You started even before you knew what you had to work with by having conversations with your community. And obviously you just, talked about, you could do that because you were in a position of trust and it informed your process. What were your members telling you about what they were facing during the pandemic? Did they talk about not only, their medical health, but did any of them talk about their behavioral health? And I'm kind of curious as to what, or were they worried about economic security, food security? What were you hearing?
I think people had a lot of anxiety. If you look at the statistics in the United States, 75% of the population, if they have an unanticipated $900 bill, it's going to throw them over the edge economically, right? So I think people were worried about job stability. I think they were worried about how are they going to educate their children. If they were working from home, how are they going to provide, for their children's, well-being while trying to juggle work and home. And again, a lot of our elders, were feeling very isolated. And that made them anxious. And I think it also made them worry about, will anyone be here if I really need something? So I think that those were some of the things that we were hearing early on.
We'll be wrapping up our session shortly. Stacey, is there anything else you'd like to share with our listeners regarding the pandemic and public health and behavioral health in Indian country?
Yes, sorry, I had to mute myself. My German Shepherd was having a German Shepherd barking moment. Yes, there are two things. I'd like to always include a call to action when I have the opportunity to be a part of something like this. The first thing is telemedicine is critical to the health of our people, and the ability for our people to use telemedicine is absolutely a game changer for us. But what we saw during COVID is that our facilities and our doctors and nurses and healthcare providers were being reimbursed about $15 per visit because it was telemedicine. This is a Medicaid number. we successfully, all of us together, successfully advocated for an increase in that reimbursement amount so that telemedicine actually had an opportunity to thrive, and physicians and our providers would actually use the telemedicine opportunity. Well, we have a temporary elevated telemedicine rate during the pandemic, and I would just urge folks to contact their members of Congress and ask that that solid reimbursement for Medicaid for telemedicine is made permanent. So that if we want to have telemedicine in Indian country be viable, that's going to be necessary to our structures. The other thing is, we're in a moment of looking at advance appropriations for the Indian Health Service. And while our ultimate objective is mandatory funding for IHS, President Biden put advance appropriations in his budget request. We're working on it on Capitol Hill. The Senate Appropriations Committee is doing their work on the Indian Health Service approps right now. They need to hear from people saying, we have to have advance appropriations for Indian health. They need to hear that message. So those are the two things I would leave with that. Oh, there's one more, I'm sorry. Those are two. The last one is, we're talking about public health infrastructure in Indian country, that it's desperately needed, but we don't have a blueprint for what that looks like a public health Marshall Plan. So we need to find the resources so that tribal leaders in Indian country can come together and determine what that future is and what the best investments would be for Indian country to achieve that public health infrastructure that we need.
Okay, folks, marching orders, call Senate approps, and tell them what they need to do, and challenge your tribal leaders to think broadly about what long-term investment needs to be. Chief Malerba, what would you like to leave for closing thoughts for our listeners today?
I think one is to celebrate that we're still here. We're still here as tribal nations, and that's really, really important. And again, I give all honor and gratitude to the ancestors. And two, we need to identify what full funding looks like and measure the gap between current day funding and full funding. Because you're right, Del, this is just the beginning, and we need to insist on full funding and full mandatory funding. Once we can understand what that gap is, then we can work toward that. But no one has been willing to do that yet. The budgeting process is very convoluted, and it asks us to set our priorities for budgeting. That's crazy. And so I think that's where we need to head.
And you got a shout out in the chat, Chief Malerba, about highlighting the government to government relationship and that this is a justice issue. We all need to speak up loud about that. Del, do you have any closing thoughts?
Yeah, very briefly, I think build around culture and resiliency and the tribal communities' histories and build on it. And then keep the gains made by telemedicine. We've got to have native providers out there who are available, that they can cross state lines and they can provide those services to tribal communities. So we need to keep that exception to the rule that's came through the pandemic. And then finally, I'd like to just mention a shout out to the University of North Dakota, that they have an Indigenous Trauma and Resilience Center. It's in the chat, and they're looking at increasing native providers, and they've just received some funding to try to look at all the different alternatives to provide for tribal communities. And if we have more partners like that, I think we'll start to see some success.
I would like to offer our sincere thanks to Chieflin Malerba, Stacy Bolin, Del Lavador, the planning committee from the Harvard Project for putting this session together today. We hope that you found it useful. So we have been having these sessions every 2 weeks to talk about the American Rescue Plan. Our next series will be in 2 weeks. It's focused on infrastructure. How can Native nations invest in infrastructure? Our guests for that session will be Lyle Echohawk, Wendy Helgamo, and Joe Valandra. And we know this is a hot topic in Indian country in terms of prioritizing and making some of those kind of hard investments in our community that are necessary. So we'll explore that more. So we hope you'll join us in 2 weeks. Please share our invitation regarding this series within your network of organizations. And then, as always, you can find further information on the Harvard Project on American Indian Economic Development website, hpaid.org, which is our website. And so we hope you and your families and your communities are well, and we look forward to seeing you in 2 weeks. Thank you all.